But if you understand the math, then you understand the theory and vice versa, you know, so it's just give us a different look at technique adjustment and what factors control what aspects of the beam and therefore what aspects of the image. So, you know, this is not graded, it's just something for you to try to work through. Right now there's 55 questions on the test. Somebody had asked how many questions on the test. I'll probably carve that down to 50. Just to make sure, you know, because we only have 50 minutes to take the test. So to make sure that you have plenty of time to take the test, I'll probably whittle that down just a little bit. So Wednesday, that's what we'll do is if you have any questions on any of the lecture material, we'll talk about that. If you have any questions, you know, if you've, regardless of whether you answer these in the module, it doesn't, you know, we're going to take a look at them in class as well as best we can. So today we're going to focus on the PowerPoints, try to get the rest of the way through that, and then on Wednesday we'll, you know, do the other. So where we left off on Wednesday was pretty much with the wrap up. Image quality factors, what image quality factors are. So what we've got is optical density, contrast, sharpness, and distortion. That's really the rest of the semester is those four things. Is the technique as it interacts inside of the patient and gives us a remnant beam that affects the exposure at the image receptor and gives us these four things. So that's kind of an introduction to the rest of the semester. And really there's a bleed over enough between each one of the chapters that it's worth, you know, talking about them on each one of these. So density is really kind of outdated because our density, and it's not really outdated in as much as what controls density. So density is still relevant. The word density in context is really just density on the image receptor, but our technique really doesn't affect density all that much anymore. What affects density more than anything else now is the computer algorithm, that lookup table that we were talking about on Wednesday. So in as much as our exposure controls the density, that's really kind of an archaic term, and we've swapped that for exposure. So your index number is your indication that you got adequate exposure to the image receptor, your S number or whatever it is that you use, right? Whereas with screens and films, it was evident on the image. The darker the image, the more dense it was. So if you overexpose the patient considerably, then you got an image density that was too high. You don't really see that anymore. It's all about the index number. So it's the overall blackening of the image, how dark the image is, and this is the image as a whole and not what we were talking about on Wednesday, individual, you know, density in a particular area. You know, we were talking about differences in patient density giving us differences in tissue the differences in tissue density giving us differences on the image. That's really your contrast. What we're talking about here is overall, the entire image either being overall too dark or too light. So it's really our index number now, and it's controlled by mass, and it's secondarily by everything else. So secondarily by SID, and lastly by KBP. So it's controlled by mass because it's a direct relationship. It's a direct relationship in every way. If you increase your mass by 100 mass, or 100%, then you exactly double the exposure to the image receptor. It's predictable, and it is direct in every way. The reason we don't use SID is because what do we introduce with SID? Changes in SID. Magnification. We either increase or decrease magnification, so we change in some ways the imaging characteristics of the X-ray beam. How much of a change in technique do you need with the change in distance? What do we call the laws that govern? Inverse square law, direct square law, right? So what does that square indicate? It's a what? No, it's a double of the change, right? So it's an exponential relationship. So we don't use SID. What about KVP? How much of a change in KVP do we need? It's direct, and also with SID, it's an inverse relationship, right? You increase the distance, then what you have is a decrease in image exposure, right? Unless you change your technique. So KVP is a direct relationship. If you increase one, the other goes up as well. But how much of a change do you need to double your image exposure with KVP?
5%.
Almost.
4%.
No, you're going the wrong route. 15%.
Okay.
15% change in KVP changes your image receptor exposure by a factor of 2, right? So it's also exponential. It's direct, but it's exponential. So 1 unit of KVP gives you more than 1 unit of density or exposure, all right? So for all those reasons, we use mass. I want to be, fully transparent here. Since I feel like this is really kind of archaic as well, in that your KVP, back in the days of screens and films, the reason we use mass is KVP truly affected the imaging characteristics of your X-ray beam, and it affected your image. You increase KVP and you decrease contrast, right? Because you get that increase in scatter radiation and increase in penetration. But what controls your contrast now? Contrast and density both. Huh? What really, really controls it?
Your
computer.
Your computer, exactly. Your computer algorithm, your lookup table controls all of that stuff. All right, so since it controls all of that stuff, I really expect, and KVP really doesn't affect your contrast that much anymore. You've got to memorize that it's the technical factor that controls your contrast, really doesn't. But you've got to memorize that. So since it doesn't really control your contrast and computer algorithm does, what I expect is some point in your career, because you're young enough, some point in your career will make a change from mass being our controlling factor of image receptor exposure to KVP. Now, why would we make that change? What kind of techniques are easier on the tube, high KVP or high mass? High KVP, because mass drives the heat. What kind of techniques are better for the patient? High KVP, low mass, or low KVP, high mass? High KVP, low mass, right? So there's every reason to make that change. It's just that the traditions of the profession really hadn't caught up to the technology yet. I expect it will. Maybe not by the time I retire, but probably by the time you retire, okay? So, all of that said, you need to look out for certain things, okay, in test questions. You need to look out for how much of a change in mass does it take to make a noticeable difference. That's not if you need to repeat an exam, that's just your baseline for minimum change in mass to affect the change on your image, and that's always going to be 30%. And realistically, even in screens and films, it was difficult to see any kind of difference just off 30% in mass. So the rule of thumb is that if your image is bad enough that it needs to be repeated, and it needs to be repeated because of inadequate mass, how much of a change in mass do you need? That's 100%, or a factor of 2. So if you change your mass, you start off with 30 mass, and your S number says that you're too low and you need to repeat it, then what kind of mass do you need? Started with 30, 60, right. So if it's worth repeating, it's worth doubling. If your index number says that you're overexposed and you need to reduce your mass, then you would just about 2. So 30 mass would be 15 mass. Your new mass would be 15 mass. So noticeable difference is going to be 30%. Right. Doubling is your baseline for what if you needed to repeat. So I'll put this in here just because we overcomplicate things. It's complicated enough and we have a tendency to overcomplicate it. Okay, so 30% change in mass gives us a noticeable difference. Okay, so of a whole, how much roughly is 30%? A third, roughly a third, right? So 1/3 of your needed mass change to double the exposure is your baseline at 30%. Does that make sense? So how much is 1/3 of 15%? 5%, right? So same thing with KVP, 5% change, because that's roughly 1/3 of what you need to change KVP in order to double your exposure, is what you need to see a visible difference with a change in KVP, okay? So are you ever gonna use this 30% or 5% rule? Outside of test questions, no, you're not, because if it's worth repeating, it's worth doing what? Double, right? So if it's a double, if you need to double just because of mass, then, or if you need to increase your exposure just off of mass, then you would change by a factor of 2, right? If you needed to affect a change in both penetration and grayscale and exposure, then you could change your KVP, right? So whenever we're talking about optical density, high optical density just means that we're overexposed, so your S number, depending on what your manufacturer is, who your manufacturer is, a low S number may indicate overexposure, and why they did that, I just don't know. But there is a direct relationship. So if your ideal S number is 200, and your the image you shot showed your S number at 100, then what's the difference there? A factor of 100 to 200 is a factor of 2. So what would you need to do to your technique, your mass specifically, in order to correct that?
Decrease.
Ideal was, okay, yeah. Because your ideal was 200, and see, I got it wrapped around backwards. Your ideal was 200, yours showed 100 on, what system are you using?
AEC.
AEC is the photocells. But anyway, so if manufacturer, a lower index number means overexposure, then that 100 would be overexposed by a factor of 2, so you would cut your mass in half, right? So the danger in overexposure, even in digital, is if you really overexpose a patient or underexpose a patient, you may burn out pathology. You may flood the image receptor to the point that it can't see the pathology, demonstrate pathology. And as with overexposure, you burn it out, or underexposure, you may, your overall density and exposure may be so similar that you can't make out the pathology, okay? What burn it in means is that you demonstrate something that you mentally think is a pathology. It's really not a pathology, okay? So overexposure, and optically, visually, you're gonna have a hard time with the difference between density and contrast, because contrast means difference, right? So you look at this and you've got good contrast, right? You got good contrast. You can see the difference between soft tissue and the bone. You can see, the difference in density along the bone. You get up here. Can you see that very well? No, you don't. You don't. So you lose contrast, but you lose contrast in this context because of extreme overexposure. Okay? So when we're looking at that, you're going to have a tendency to look at that and say, I've got no contrast there. Well, you're right. You have no contrast there because everything is so dark you can't see it, right? So you lost contrast because of overexposure. Underexposure can do the same thing, but what you get is this kind of milky appearance here, okay? So when we're talking about density, we're talking about, again, the overall blackening of the image, the darkening of the image, and how dark the overall image is. Very low density, very high density, okay? So adjusting for pathologies, we talked about this on Wednesday. Your baseline is going to be 30 to 50% change. If you know, you have an additive condition, then you're going to increase your technique by 30 to 50%, and that's mass, right? Again, I expect that will probably change in your career. So additive pathologies, you're going to add mass. Destructive pathologies, you're going to reduce mass. But there are times that you may need to change your KVP, and we talked about some of those. Some of those are kind of confusing. But pretty much, what kind of tissue types are you going to increase your KVP for? This just says ZEF number, right? Z number. But really, that doesn't hold true, because we talked about if the patient has pleural effusion, which does increase your ZEF number. What kind of tissue types would you increase KVP for? Bone. Bone is your go-to true tissue type, but certain types of contrast, barium, not iodine, but barium, you're going to increase your KVP. Prosthesis, you know, if a patient has a metal prosthesis in, then you might increase your KVP. So probably 9 out of 10 times your change is going to be mass, and that change is going to be 30 to 50% change in mass. Okay. Also with KVP, again, if you've got plaster casting material, you would use that as well. So radiographic contrast is the difference between the dark areas and the light areas on the image, and that's what contrast means, is difference, right? So it's caused by attenuation, caused by the differential absorption. So differential absorption just means that. It's difference in absorption in different tissue types. So you got bone versus soft tissue. You got different tissue types. The bone shows up much brighter than the soft tissue. And so because you've got that difference in absorption, you got more absorption in the bone, less in the soft tissue. That difference in absorption is what gives you the radiographic contrast. All right, so you have to have differences in patient density in order to give you differences in radiographic density, which is your contrast. So again, your computer algorithm is truly what controls it. But the technical factor, and that's what you need to be looking for on your test questions, is the technical factor you would use to affect a change in differential absorption. The technical factor that you would use to affect a change in contrast, in radiographic contrast, is KVP. All right? So if you go to clinicals Tuesday, you know, you can play around with this. You can find something to shoot. If you've got a skull phantom, that's great. But, you know, start with 75 kVp, increase your kVp to 85 kVp, and shoot it with a phototimer, and tell me how much of a difference you see in the contrast. It's not going to be all that great. And then drop it down to 65 and shoot it again. It's not going to be all that great. So your computer algorithm is truly what changes it. And I think that's part of the reason this has always been hard. This has always been the hardest part of the curriculum. That's why we cover it 4 times. But I think it's harder now because you don't truly see it. You know, I stand up here and I run through all this garbage, and you don't see it, you know? So you go into clinicals and you shoot all this and you say, you know, I don't get it. Well, that's because your computer algorithm fixes it for you. The science behind it and the differential absorption still applies. It's just that processing has changed so much in the last 10 years, 5 years even, that the visually, you just don't see it all that much anymore. So grayscale is the opposite of contrast. So things that are synonymous. Grayscale, if you've got a long grayscale, then you've got a lot of different shades of gray, all right? So when you're looking for high contrast, you want very few shades of gray, okay? So you want not very many. So shades of gray, a lot of shades of gray is long scale contrast. Short scale contrast is high contrast, all right? So short scale contrast, high contrast. a lot of shades of gray is low contrast, or long scale contrast, and also, just lost the word, it'll come back to me here in a minute. So it's, your contrast is overall the range of optical densities that you can see. And a lookup table applied to your algorithm is really what controls your contrast. KVP, again, is what we say we use to control contrast. It's a technical factor we use to control contrast. It came to me and I left right away. It's forgiving is the definition of the word. What? Latitude, thank you. Latitude. So long latitude, high latitude means long scale contrast. If you got a lot of latitude, you got a lot of gray scales or shades of gray, and you got long scale contrast, low contrast. So, radiographic contrast being the difference in optical densities between adjacent structures, that's what you're going to look for. You're going to have a tendency to confuse two things. Well, a lot of things, but in this case, two things. You've got sharpness of reported detail, and then you've got visibility of reported detail. Sharpness of reported detail is truly the line, the edge of the line, and whether or not you can see that. You know, you've probably seen a TV station kind of go off the air, and then you get this little test pattern that shows, you know, like lines and stuff going across, or maybe your computer. That's your actual sharpness of reported detail, whether or not you can see those lines. Visibility of reported detail is all about contrast. Can you see, it's not whether or not those lines are there, it's whether or not you can see those lines, okay? So, when we're talking about sharpness of reported detail, we'll usually mention just detail, right? If we're talking about contrast and visibility of reported detail, we'll say visibility of reported detail or resolution, okay? So resolution, just resolution itself is detail. Contrast resolution is just contrast, okay? It's just contrast. So contrast is the difference in optical densities caused by the differential absorption inside of the patient. High contrast just means black and white, it's short scale, and that's low latitude. Low contrast means we've got a lot of shades, we've got a long scale contrast, and it's high latitude. Okay? So, you know, you might clip that and stick it on your mirror and just kind of read through it a few times every day until, you know, it kind of locks in, because you're going to trip over this for the next 2 or 3 semesters. So again, KVP is what we say. The main thing that controls your contrast is the lookup table. KVP is a technical factor we adjust. 15% rule, we walked through that earlier. If you need to adjust your image receptor exposure using KVP, or I'm sorry, you want to affect your image receptor exposure, and you want to use or affect a difference in differential absorption, you would use KVP. So, in the 15% rule, or in changing KVP to affect image receptor exposure, read the questions carefully. What you're going to see are one of two things, all right? You want to change your scale of contrast, and you want to maintain the same density or image receptor exposure. Then you're going to use your 15% rule, all right? So if, let's say, the question says you want a longer scale of gray, longer grayscale, you want lower contrast, you want an image with more latitude. What do we do with our KVP? So you're going to go in the wrong direction with it. It's tough. You're going to increase, okay? KVP, the higher the KVP, the more grayscales that you're going to see, okay? So as KVP goes up, our differential absorption goes down, we get more penetration, we get more scatter radiation, and that gives us more grayscales, okay? So if your question says that you want a longer scale of gray with a you want to repeat an image with longer scale gray. Stop there, okay? So figure out what that means. KVP controls your grayscale. So you want more shades of gray, you want more tissues penetrated, you need higher KVP. Okay? Then move on to the next portion of the question. The next portion of the question may ask you to either maintain the density or exposure, or it may ask you to increase or decrease the exposure. Okay, and so this is kind of getting into the prelude for the questions I posted online. So if you increase your KVP and that's the only thing that you do, according to the BRIM spectrum, what's going to happen to exposure to the patient? Goes up very dramatically, right? So a 15% increase in KVP equates to how much of a change in mass? Factor 2, right? So if you increase your KVP by 15%, you want to maintain image receptor exposure, then what are you going to have to do? You increase your KVP by 15%, your dose goes high. Yeah. So what do you do to bring that dose back down?
Decrease mass by factor
Cut your mass in half by factor 2, right? Now, what if your index number showed that you underexposed the patient, so you need to repeat, but you also underpenetrated the patient? Now what do? You need to increase both? Well, let's walk through it. So you need to repeat an exposure, and you need to affect a change in penetration. So which way do we go with our KVP? Up, right, so we go up. We go up, we hadn't done anything with mass, what happens to our exposure? It goes up too. Right, so what do you do with your mass? Leave it. You do nothing. Okay, because our question says that you showed inadequate exposure and inadequate penetration. Okay? So now I'm going to make it really complicated. So what if your question asks you, you need to increase penetration, but you overexpose the patient? Your original image was underpenetrated, but overexposed.
decrease decrease KVP.
Okay, wait a minute. You were underpenetrated, increase KVP, decrease mass just by the factor 2?
By factor 2?
Probably by factor 4, because what's the general rule? Cut it in half, right? So as you increase your KVP, you fix the penetration problem, right? You cut your mass in half, and that brought you back to your original exposure, but your original exposure was too high. Is that, which, I forgot the question, that it was too high, right? So what's your general rule? Cut it in half, right? So what you would do is increase your KVP, cut your mass in half a second time. Okay? So when you get to these questions, just take them one thing at a time. You know, you read the whole thing and you're going to get confused. But if you read, start with KVP. Well, what does KVP affect? It affects contrast. As KVP goes up, contrast goes down. As KVP goes down, contrast goes up, right? So fix your KVP before you move on to your exposure. Just take them one step at a time, okay? So a 15% change in KVP with an opposite change in mass only affects contrast but not exposure. A 15% change in KVP without a change in mass changes contrast and exposure. Right? So in contrast, we've got long scale contrast, gray. We've got high contrast, and stark differences, right? So we have to have both, really. You can have an image that has way too much contrast and you can't really make a good diagnosis off of it. And then we can have an image that is so gray that we can't really make any sense out of it either. So we have to have a balance between the two. We have to have grayscale, we have to have contrast as well. So there's a balance between the two. This looks a little washed out, this looks a little bit too high, both of them are really not that bad at images, but, you know, going back to the one we saw before, yeah, just ugly and ugly on both ends. And, you know, these down here are much closer together, but look how low a contrast this is compared to, you know, that more gray. Can you kind of see that? It's more gray. The soft tissue and the bone are more similar in appearance than what they are over here. So contrast, what controls it? KVP, no, not really. You gotta know that's the technical factor we use, but it's really controlled by the computer algorithm. But the KVP still does affect the differential absorption inside of the patient, which without the KVP and without that differential absorption, we wouldn't have an image at all. So if you go into clinicals and you find something to shoot, and it doesn't have to be skull phantom, it could be a sharps container or whatever. But if you get into the extremes, you shoot something at 40 kVp versus 110 kVp, you're probably going to see a little bit of a difference between the two, even if you phototime it, you know, because the differential absorption gets so high at low kVp and so low at high kVp. So really, the imaging system characteristics are what control your contrast now, and that is your processing algorithm. That's just a mathematical equation. That's your lookup table applied to your histogram. Both of them, again, are histograms. The lookup table is just a stored histogram that your computer is going to compare against yours. The H&D curve we'll talk about, and it's a throwback to film. It stands for Herder and Dreifield, and it was borrowed from photography. And what it does is it gives us the imaging characteristics of the imaging system. And since the stored lookup table, the algorithms inside the computer are just these graphs of lines representative of densities, it's hard to make sense out of it. So we still use the H&D curve, and we use it to identify the imaging characteristics of the lookup table. What I mean by that is, if we have a lookup table that's supposed to be representative of high contrast film, right? Then what the H&D curve, will apply an image of an H&D curve that should represent that particular set of contrasts. All right, so what the H&D curve was both it's a S-shaped curve that identified minimum exposure, maximum exposure, minimum density, and maximum density. So what we have is a density curve, a density axis, and an exposure axis. I just wrote that backwards. Exposure axis and a density axis. Okay? So this is radiographic exposure, right? This is the exposure to the image receptor. So on film, the more exposure we have to the image receptor, the higher the density we have. So if we shoot a hand with 100 mass, then what we're going to have is density that's so far off the charts that, you know, it's going to burn all the anatomy out. You can't see it. Okay. If we shoot the same hand with, you know, 20 kVp at a fractional mass, then our image density is going to be very, very low. Okay. So in the H&D curve, what we can identify is high contrast, low contrast, maximum and minimum exposures. And really the speed of the image receptor system, which we'll talk about later. But if we have exposures that take us from minimum density to maximum density with very few changes in the amount of exposure. So low mass, slightly higher mass, we go from very light to very dark. What does that sound like when we compare it to contrast? We go from very light to very dark very fast. Does that sound like high contrast, or does that sound like low contrast? Sounds like high contrast, right? So rolling it back to this image here, we've got low density to very high density and very few shades in between, as opposed to over here, we've got low density to very high density with a lot of shades in between, right? So we've got low contrast, we've got high contrast, and in the H&D curve, when our exposure, it doesn't take a whole lot of exposure to go from low contrast to high contrast, then what we have is an H&D curve representative of a high contrast image receptor system. Okay? So you shoot a hand, you get it deep into your computer system where you can actually look at the lookup tables, and it's going to have an H&D curve that it assigns to a lookup table that is high contrast. So it's going to look like this. It's very straight. It goes from low density to high density with very little change in between. As opposed to a chest X-ray, do you want high contrast on chest X-ray? No, you want to see a lot of different shades of gray. So the lookup table, or the H&D curve that is representative of the lookup table for low contrast, we'll say this is a hand, this is a chest X-ray, is going to take more exposure in between density levels. So it's going to be more horizontal. Okay? So we'll study the H&D curve later in the semester, and we'll definitely look at it in the fall semester of after summer. Not of next year, but after summer. But that's basically what it is. It's a throwback to film and something we can make sense out of, that we can visually look at a lookup table and say, yeah, that's high contrast versus that. No, that's a low contrast. Okay. So detail, again, if you just see detail, it's going to be actual detail. That's the lines as opposed to visibility recorded detail. Visibility is all about contrast. So detail, resolution, without any qualifier to it, is how sharp are those lines? Are they fuzzy or are they truly sharp? All right, so that is our spatial resolution. It's sharpness of the appearance of the structures. It is our recorded detail. That's the actual lines. Are the actual lines there? And are they sharp? It's controlled by our geometric factors. What is geometry? Yes, yes, man. Lines, angles, right? So positioning controls your detail. Positioning of the central ray. Do you have an angulation on the central ray? Do we see presence of elongation or foreshortening, right? Do we have magnification? Those sort of things control our spatial resolution. Our focal spot size controls is what we use to control our spatial resolution. So do we use the correct SID considering the OID that we have? You know, you shoot a lateral C-spine. What kind of distance should you use for a lateral C-spine? 72 inches. Why?
Because there's a big gap.
Because you got that air gap. We've got an increase in OID. Why do we shoot a chest X-ray at 72 inches? When we can. Magnification of the heart. Why would we shoot a chest X-ray? PA. Same reason, really. Put the heart closer to the image receptor, right? So anything that can cause a difference or an unacceptable or unwarranted or unwanted change in our geometric factors is what controls the sharpness of reported detail, our spatial resolution. And that's everything that we can do, but also there are imaging system characteristics. You know, what controls how sharp that image appears. You go buy a TV. What are you looking at in a TV? Pixels. Pixel sizes. Pixel sizes. Pixels are the individual little bitty pieces to this picture, right? So what you want is a lot of pixels in what we call a matrix. So the matrix is the overall size. So whenever you're looking at TV and it says 720 by 1080 or whatever, that's individual pixels in that matrix. So you want a lot of pixels in a matrix. So the smaller those pixels, the more sharp the image. Now, your monitor in the Lightroom, or whatever you're calling it now, it used to be the Lightroom because it's where we put the lights to hang the x-rays. Your monitors are fundamentally no different than this one, okay? And this one's good for reading stuff off of, but it's not good for making a diagnosis, right? So you make an exposure, and we kind of talked about window and leveling, or was that sophomores? Window and leveling, changing your contrast and density on your image, right? So the general rule of thumb is that if you make an exposure and you adjust that image so that you can see it a little bit better on your monitor, you might process out some important information before you send it to the radiologist so that he can make a diagnosis, okay? You're using a low resolution monitor. His monitor is much higher resolution. So what you do to the image on your screen to make it look good may destroy the image on his screen. So, don't ever do that. You can adjust the image, but make sure that you save the original so that you can send it. All right, so visibility, that was sharpness reported detail. Visibility is just anything that covers the sharpness, usually fog. What controls the fog? What what technical factor controls fog? KVP, right. So we're going to talk about later in the semester how to deal with the KVP and how to limit the fog with changes in KVP as well. So fluorescent lighting, if you're using a CR system, fluorescent lighting can lay down a layer of fog on your image receptor. So anything that produces scatter, KVP, tissue type, lack of collimation, and we'll talk about all that later in the semester, whether or not you use a grid when you should have used a grid. Beam restriction is your collimation. So all of those things can affect a change in visibility of recorded detail. Beam restriction, collimation has become more important. It has always been important, but it's become more important for reasons that we didn't really expect to see, and we'll talk about those later in the semester as well. So distortion, again, is geometric. Actual sharpness reported detail issues. So the different types of distortion, we've got magnification, which is just size distortion. And size distortion just decreases the sharpness reported to any kind of distortion, decreases sharpness reported detail. The magnification will decrease naturally as SID decreases. It increases as OID increases. Now there are times that we want to increase an OID without a change in SID. It's rare. And we used it more in screens and films than what we do now, but it still has an application. That is what we call macro radiography. Macro radiography is an intentional increase in OID so that we get magnification. It used to be used a lot in special procedures. It still is used, but not in the same context as what it was used before, okay? So we get an increase in OID. What does an increase in OID do to your image? What's that? Magnified. Yeah, you get an increase in magnification. With an increase in OID, you get an increase in magnification, right? So in special procedures, they're looking at putting, fixing small aneurysms inside the small blood vessels inside the patient's brain, right? They're hard to see, so they increase the OID to increase magnification. So if they increase OID to increase magnification, what are they going to lose? Sharpness of recorded detail, right? So how do you reintroduce that sharpness of recorded detail? You would think so, and that's what we've been talking about, but no. So we're gonna complicate this too. You had something that was, you had down, right? Increase OID, increase SID, but what happens if you increase SID after you increase OID?
Changes the magnification.
Yeah, your magnification goes back down. You want the magnification in this case. So the only thing that you can do, you remember talking about focal spot size?
This is small.
All right, you use a very small focal spot size. So what they use, and this is a technique they call macro radiography, M-A-C-R-O radiography. And what it is intentional magnification. So it's an intentional increase in intentional increase in OID without an increase in SID so that you intentionally magnify the image. Unfortunately, because you're doing that, you're increasing OID without increasing SID, you're going to lose sharpness for recorded detail. And the only way to overcome that is by using a very, very small focal spot. And that's a fractional focal spot that we mentioned earlier on in the semester. Okay? But if you don't use a small focal spot, you're going to increase penumbra. All right? So two words, umbra and penumbra. We don't usually mention umbra, but umbra is sharpness. So you can file that in with, all those other words we talked about before. Umbra equals sharpness. Penumbra is unsharpness. All right, that's a fuzziness at the edge of the image is penumbra. Okay, so the increase in OID increases penumbra. Other things that can increase OID is body habits. Okay, how does body habits increase OID? You got somebody who's aesthetic, and even their shoulders are only about that far apart. Or let's say you've got a patient, not necessarily body habits, just body size. You got a pediatric patient you're shooting a lateral C-spine on. Where is their C-spine in between their shoulders are only that big? Right in the middle. So you're looking at a 4-inch increase in OID. And you get one of these great big domers, and he's this wide. Now how much increase in OID do you have? More, yeah, a whole lot more, right? So body habitus and body thickness, body size can increase OID, and in that way increase penumbra, and you lose sharpness for recorded detail, as well as magnification. So body thickness, body position as well. Give me some examples of some body positions that we've talked about so far that are better in one projection as opposed to the other. Just mentioned one just a little while ago. A C-spine, yeah, but it doesn't really matter if it's left lateral or right lateral, but what about chest x-ray, right? Chest x-ray, we shoot PA, so we put the heart closer to the image receptor, as opposed to AP elevates it, right? Ribs, we talked about ribs last semester. Ribs, rib cage looks kind of like this because we've got, sternum and we've got costal cartilage. So as we oblique the ribs, AP obliques put the axillary portion of the ribs closer to the image receptor as opposed to PA elevate, right? So body position can play a part as well. Object shape also plays a pretty good part. All right, so I wish I had a bigger ball. How do I put the thickest portion of this ball close to the image receptor? If this was a steel ball, how would I put, what is the thickest portion of this ball?
The middle.
The middle. Yeah, if this was a steel ball, how would I put it closest to the is a trick question, closest to the effective image receptor here? You can't, right? So certain objects, you're always going to have an increase in OID. You just can't do anything about it. Other objects you can, right? We talked about wrists. Which projection do we shoot wrists? PA, right. We said, though, that the wrists are cone-shaped with the anterior surface more pointy than the posterior surface, right? Again, it's another thing I've never really understood. So if the anterior surface is more pointy and the posterior surface is fatter, then which projection would actually be better to shoot your wrist? Would it be AP or PA? Really, AP, right. Why do we do PA? Your guess is as good as mine. So macro radiography we talked about, that is intentional increase in OID with no increase in SID, right? The only thing that we can do to increase that sharpness, reintroduce that sharpness, is just use fractional focal spot. Air gap technique is really kind of not the same thing. We get if we could take the patient's shoulder off and put them directly up against the image receptor for a lateral C-spine, that'd be great, but we can't. It's not an intentional increase in SID or OID, but we do increase SID to compensate for it. Macro radiography, though, is an intentional increase in SID and OID to increase magnification without increasing SID. The distortion, we talked about magnification. Distortion is shape distortion. That's unequal magnification. So we've got this, and if our central ray is perpendicular to this, then we see the true dimensions of the pin, right? But if I angle it, what I get is an increase in OID on this end, so I get a fatter appearance on this end. This end didn't really change, so it remains about the same. So I get unequal magnification. Magnification increased down here, didn't really change down there, unequal, right? As opposed to magnification is, equal magnification is your size distortion. Generally, when we just say distortion, it's going to be one of two things. It's either going to be foreshortening, which is what we get here, which is usually caused by a change in body position relative to the central ray and the image receptor, or elongation, which is generally angulation of the central ray. Okay. All right, so technique charts, and this is where we're going to end. Technique charts, we've really got three different types of technique charts. Most of your technique charts are really inside of your system, and that's what they call automatically programmed radiography. APR is really the system you're using. But what it uses is something like one of these. Okay, so you got a variable technique chart, you got a fixed KVP chart, or a variable KVP, fixed KVP, and high KVP. So with a variable KVP chart, what you have is you adjust your KVP according to the patient's thickness. All right, so you have a hypersthenic patient versus asthenic patient. Instead of adjusting your mass, you got a baseline mass and you just adjust your KVP. Again, in screens and films, that gave us contrast issues. I expect that, again, in your career, we may be going back to a variable KVP system. But with a variable KVP system, what we have is contrast issues. Oddly enough, of the different types of technique charts, we get higher contrast off of variable KVP systems than what we do with fixed KVP systems. That's fundamentally because you're trying to use as low KVP as you can and still penetrate the tissue, so it tends to be low KVP. Fixed KVP are more common as kind of what we use. So you use an adequate KVP and then you adjust your mass, right? So you have asthenic or let's say a hyposthenic patient for a KUB, you probably have a baseline KVP of maybe 80 to 85 KVP, and then mainly what you adjust is your mass, right, for patient size. So that's your fixed KVP. So variable KVP, the mass is relatively fixed, the KVP adjusts. Fixed KVP, the KVP is fairly well fixed, the mass is adjusted. Then high KVP is where we use, or what we use for barium work and chest x-rays and things like that. Okay. High KVP just because we need increased penetration and a decrease in differential absorption. Okay. We'll talk about AECs. before we get into the questions next week. Any questions on all this? Yep.
Going back to optic density, you said that mass changes to make a change of over 30%. The book says that the KVP, however, is costing 40%. Does that matter?
It really doesn't matter. We're gonna use 5%. That's been industry standard for forever. So we're gonna use 5%. Does it say 4% or does it say 4 KVP?
It says 4%.
4%, yeah. We're just gonna use 5%.
And going back to, it was chapter 5 through 8, is thermonic emission the same as space charge?
Yeah, thermonic emissions, space charge, same.
Okay.
Yep. That's just the heating of the filament until you get those electrons ready to send. Yep.
Whenever you were talking about index number, is index number another word for the S number?
Yeah.
Okay.
Yeah.
Okay.
I use index number because not all manufacturers use
Right.
S number.
Right.
They have different names for it. Now, that's something that I really think that there should be been an industry standard, because some use a scale of 1 through 4, some use 100 through however high,
And
Some, if the exposure is too high, the number is low.
Right.
Some, if the exposure is too high, the number is high. There's no consistency.
so the S number is exposure?
Yeah,
factor?
exposure
Okay.
index number.
Okay, got
Yep.
it.
You
Yep.
also said that, or you mentioned that mass changes contrast too?
Mass can change contrast, but in the extremes. Like, going over here to, so that you've got this on the recording. So going over to our H&D curve, and I got y'all off the image, so you don't have to worry about being on. They can't see it. They could for a second. So if your exposure is so low, all right, see how both H&D curves flatten out on the top and the bottom? If your exposure gets so low that you just don't have enough signal to the image receptor, you're going to lose contrast. And if you use such a high mass value, or even KVP, that you flood the image receptor, and all of your individual little detectors inside your image receptor are so oversaturated, then you're going to lose contrast as well. Okay, so this equals contrast, right? The vertical portion equals contrast. So anytime you come out of that verticality, you lose contrast. So overexposure, lose contrast. Underexposure, lose contrast. So was overexposure caused by too much KVP or too much mass? Either one, really. So yes is the short answer, is that you can lose contrast in the extremes if you over or underexpose the patient using mass.
So the main one that would change contrast that we're studying is KVP.
KVP, right. But in the extremes, mass can affect your contrast. But you're looking at way overexposure. You're shooting a hand again at 30 mass, or you're shooting a KUV at 2 mass, something like that. So in the extremes, mass can affect your contrast, but what you use to affect the change of contrast is KVP. Okay?